Good morning. I hope that everyone who's tuned in is ready to participate today in our Kolokotrones lecture. And this one is hopefully going to be something that we all have not only an interest, but a passion for, because it is one that takes a lot of heart. So this morning's lecture is Patients, Parents, and Providers. And this is taken really the theme from our chapter in the consensus book from the World Glaucoma Association consensus book on childhood glaucoma. This morning, I'm trying to change my slide. This morning, I want to also mention that our panel has been somewhat shortened and abbreviated. I will tell you a little more about that as we move on. But before we really get into the meat of this morning's lecture, I want to thank the Kolokotrones family, which has made this all possible. Our first Kolokotrones lecture had a wonderful panel, Jamie Wigg, Terry Young, where we dove into the genetics in childhood glaucoma, and was a terrific meeting. And this morning I hope will be the same. And what we want to explore today is really the interaction between having a chronic and serious eye problem that intervenes in what should be probably some of the happiest times in people's lives, having a young child, a newborn, that is suddenly born with a diagnosis that can be shocking to most. And one of the things that we want to explore, and one of the things that has become evident over the years of doing this work, has been that there are unique stressors for every part of the picture, whether it's the patient, whether it's the parents, and the doctor as well. And also it really depends on where people are located, and these stressors can be different. And the whole interaction is unique in each case, and yet there are some underlying and common themes. One part that we really want to explore, and I think we will be able to get to in our second session of this Kolokotrones lecture, is the hand in glove interaction between the components that produce the stress, the recurrent stressful events that occur in these children, as well as how it interacts with the child and their development. And one thing, as we think of quality of life issues in our kids with pediatric glaucoma and other anterior segment dysgenesis, is that how does this affect their development? It's actually a question most parents ask us, and I have to say most of the time we're able to reassure the parents, but quite honestly, it's something that I felt I needed to learn more about. And I certainly knew that it was a hand in glove relationship with the quality of life. Quality of life issues in these kids has been looked at a little bit more than psychosocial development. And so we are going to be breaking that down today. This speaker, Dr. Rahi, who many of you I'm sure know, who's a pioneer in quality of life in this group of children in this very vulnerable population, unfortunately has had to reschedule, but as she said to me, this is going to be somewhat of an advantage so that we can dive into each section separately, and she will be giving her portion sometime in early 2022, probably January. We're coming up with a date and we'll announce that at the end. But here with us today is Dr. Alan De La Meter, who is a professor here at the University of Miami. He is a child psychologist, and he works with children with chronic disease quite frequently. A lot of publications with children with diabetes and how their development is affected. And Alan has graciously joined us this morning, and we're able to dive into the area which I think most ophthalmologists haven't explored in this group of kids, and that's the psychosocial development. And again, I think this is one which impacts ultimately quality of life extremely. He'll briefly review some of what we know about the quality of life, of course, leaving much of that for our second session, and then talk to us about how we should what we know about psychosocial development in these kids with a chronic stressor in the family, and how it's affecting the child and the family, as well as how maybe we could all move on and see the future together to come up with more answers. I will say that joining us today with Alan is Dr. Peter Chang, who is part of the Balkan Center, Dr. Elena Bitrion, another surgeon and a member of the Balkan Center. And I'm Alana Grajewski, and I want to thank you for joining us. I'm going to stop sharing the screen, Alan, and let you come on.
Thank you very, very much. I really appreciate the opportunity to speak with you today, especially Dr. Grajewski and Dr. Chang for inviting my involvement in this topic. As Dr. Grajewski said, I've been a pediatric psychologist for many years and really focused my work on kids with chronic illness with a focus on diabetes in particular. And I just recently got very immersed in the literature on the impacts of child eye conditions, glaucoma in particular, and other conditions. So I'm learning a lot about this, but I was trying to get my slides to move forward. There we go. So in the next 30 minutes or so, what I'd like to do is examine the research on the topic of psychosocial development and quality of life in kids with glaucoma. In particular, looking at psychological and social adjustment, cognitive development, and academic achievement, and family functioning. Then discuss the implications of this literature review for future research and clinical practice. And then let's just consider research on psychosocial development and quality of life more generally with regard to visual impairment. And then finally, I'd like to talk a little bit about integrated behavioral health care. Thanks to our research associates, they did a very great job in looking at the literature. And the first thing they did was do searches using these terms of psychosocial adjustment, cognitive development, academic achievement, family functioning, and pediatric glaucoma. And look what happened. They found 3 articles. The literature search also revealed, and those 3 were all on family functioning, interestingly, and 6 studies on quality of life. So let's take a look at what that shows. In terms of family factors, almost 10 years ago, Friedman and colleagues looked at parental health literacy in relation to medication adherence of kids with glaucoma. And they did find actually that in a prospective observational study, overall good adherence, but only 41% of doses were taken within the time frame that as prescribed, and lower adherence was associated with lower parental health literacy. So their conclusion was that children who had glaucoma and who had parents with low health literacy were at risk for less adherence. There were also a few studies done, this one in India in 2013, that looked at caregivers of kids, almost all parents, and they completed the caregiver burden questionnaire and found that almost, the majority of them experience moderate burden and some experience severe burden of caretaking, whereas about a third of the parents were actually reported significant depression. So this finding certainly suggests that parents and other caregivers need support themselves in caring for kids with glaucoma. Another study similarly, but this one done in China, also found that most parents reported moderate burden. and in this study was associated with longer duration of the disease and lower educational and income level of parents. Now, just a word about quality of life before we delve into some of these studies. This has certainly become a central outcome for healthcare and health policy, and has been increasingly recognized as an important factor in outcomes assessments in chronic disease management. We think about this construct as being a general well-being construct, or one that is more specifically health related, but it is multidimensional. And as back in 1947, the World Health Organization really defined this construct as one that consisted of the disease state and physical symptoms associated with disease, as well as functional status, psychological functioning, and social functioning. And more recently, we think about health-related quality of life in children specifically as referring to the subjective and objective impacts of dysfunction associated with illness, injury, medical treatments. The core domains include, therefore, the disease state and its physical symptoms, functional status, meaning the ability to perform age-appropriate activities, psychological functioning, what we normally think of as mental health, emotional and behavioral problems, social functioning, the ability to really maintain good social relationships, and with children, we're talking about peer relationships, as well as neuropsychological and academic functioning. Of course, in older adults, of course, we're talking about job performance, but in kids, that means how are they performing in school? Well, let's look at these studies that looked at kids with glaucoma. And here's one study in 2014. Again, these are the same researchers that did the parental health literacy. This is at Duke. They used an instrument called the impact of vision impairment on children to measure vision-related, specific vision-related quality of life, and found that better visual acuity was associated with better quality of life, not surprising, and did not find any relationships with medications, number of surgeries, and all that. But these authors did consider quality of life as a crucial outcome variable in evaluating their treatment success. So it's not just surgery, medical management, it's also quality of life as an important outcome variable. A study was done in Saudi Arabia, again, a cross-sectional study, no control group in this one, but these authors did find that using their cut scores on the measure that was used, the Cardiff Visual Ability Questionnaire for Children, the impact of vision impairment, that about a third of kids had reported poor quality of life, and that was associated with lower visual abilities with bilateral glaucoma and 3 or more surgeries. So improving quality of life with psychosocial involvement, visual rehabilitation by the use of aids and so on was really considered to be an integral part of the treatment plan. A study done in the UK looked at a little bit of a larger sample, 119 kids with glaucoma, and using the Cardiff scale again, but this time also using the PEDS QL. I'm going to say more about this measure a little bit later. All scores were reduced. And on the PEDS QL, which is a generic measure of quality of life, the psychosocial scores in particular were lower than the physical scores, physical quality of life symptoms. Older kids reported less impairment than younger, and parents, interestingly, reported greater impairment on their kids than the kids themselves reported themselves. That's an interesting finding that gets repeated, not only in the vision literature, but also in the chronic disease literature at large. These authors concluded that glaucoma and its management did have a marked impact on quality of life. And in fact, using the PEDS QL scores, and comparing to other studies in other chronic illnesses, the kids with glaucoma had scores very similar to those reported by kids with severe congenital cardiac defects, kids who had undergone liver transplants, and kids who were being, who had leukemia. So, it's a pretty low quality of life as reported by these kids. Here's a study in Spain using a couple different questionnaires where, again, kids report better quality of life than their parents do about them. But quality of life and visual function were related. And the authors did conclude that functional loss has an impact on quality of life in kids with glaucoma. And this is a study done in India, another study in India, looking at primary congenital glaucoma and secondary, and comparing those two in a cross-sectional study of over 300 children and kids with primary congenital glaucoma actually reported better quality of life than those with secondary, despite having similar visual acuity. And then finally, a recent study by Lesky, and this study done in the US, evaluated quality of life, functional vision, and a range of pediatric conditions, including glaucoma. But it was a big sample of over 1,000 kids with an eye condition. And this study did have a control group of visually normal children and evaluated across 3 different age groups, the preschool, the school age, and the adolescent years, and found that quality of life scores were significantly worse across all these conditions compared with visually normal controlled children. So they used a measure called the PED-IQ that detects quality of life, vision-related quality of life, and functional vision, and concluded that it had utility for clinical practice to be used in clinical trials. I'm not going to talk about today all the different measures of quality of life. That will leave for part 2 with Dr. Rahi. But in any case, there are several measures out there that really do measure reliably and provide valid measurement of quality of life. So this is not a really huge literature base in terms of psychosocial development and research in pediatric glaucoma. I'd say it's limited, very limited. There's really no studies of psychological and social function, cognitive development, and academic achievement for this particular patient populations. We know little actually about the family factors that relate to child functioning and medication adherence, but it does appear that caregiver burden is a significant issue, and low parent health literacy is also linked with lower medication adherence. So there were several studies of quality of life in this patient population that do appear to show lower quality of life, but let's keep in mind most of these studies are cross-sectional relational designs. They have limited sample size with the exception of the last study I just mentioned, and most have no control groups. So given the findings of decreased quality of life in children with glaucoma, we actually need way more research that can address factors predictive of quality of life, besides visual ability, bilateral conditions, and number of surgeries. What other factors are predictive? And as well as more factors that address generic quality of life. More research we need clearly to look at psychological function, social and cognitive development, academic achievement, all those factors, in addition in relation to health outcomes and management of eye disease. Prospective longitudinal studies with large and diverse patient samples are especially needed. And I mentioned Tadek's publication from over 10 years ago that really did point out that many of the studies in vision loss, in pediatric vision loss, are limited in terms of the participation rates, particularly of lower income, ethnic minority children. And in fact, a lot of them that participate in research are in fact more educated and more likely to be white, of white ethnicity. So we need more diverse patient samples and to find out about the course of psychosocial development and factors that predict health outcomes, as well as interventions to improve quality of life. Now, clinically, I'd say based on this limited research, we probably could conclude that attention to quality of life issues should be part of clinical practice. Regular monitoring of quality of life, both generic and vision related, that use standard measures, I would say should be done annually. Regular screening for psychological adjustment problems can be done using brief, reliable, valid measures for kids who can report on their own symptoms of things like depression and anxiety, as well as parents as proxy reporters of their kids' quality of life, as well as their behavioral and emotional adjustments. And parents, I think, should also be screened for caregiver burden. Referral behavioral health specialists can be made then based on these screening results and these assessments that could be incorporated into regular care. So addressing these issues, psychosocial development and quality of life, I think is really an important part of comprehensive patient-centered care. Now, we weren't satisfied with a lit review of just, of 9 studies, basically. So our research staff did conduct additional review of these same factors of psychosocial development, cognitive, academic, as well as family impacts and quality of life in other, using broader terms such as vision loss and blindness. And here we see that there were 11 articles that were obtained. When we looked only at cataracts as the patient population, we see we've now increased to 24 papers. But interestingly, the majority are in quality of life. So when we look at cataracts, we've got only one article each for psychosocial function, cognitive development, academic, and family impacts in looking at pediatric cataract. And amblyopia, again, 24 articles were obtained. 7, though, on psychosocial development, 2 on cognitive, 2 on academic, and 13 on quality of life. So we have, when we broaden the terms to looking at broader visual loss and conditions in children, about 60 papers that we can look at, the majority of those being in the area of quality of life. So I just want to highlight some of these findings. I'm certainly not going over all 60 of these papers, but I do want to point out a few. So with looking at just general visual impairment, in Finland, for example, kids are reporting fewer friends and more loneliness. In the Netherlands, kids are reporting the need for more social support. Children with amblyopia do report lower social acceptance. And there are reports of higher rates of depression in blind and more significantly visually impaired youth in Pakistan. There was an interesting study done by Pinkhart and colleagues that did show visually impaired kids had a little bit more emotional and peer relationship problems and total difficulties in kids with normal vision both in cross-sectional and in longitudinal study, especially if those kids had early onset. And a recent study in China indicates that parents report more attention problems in kids with congenital cataracts. And finally, there is a report of greater conduct and externalizing behavior problems in kids with strabismus. Fewer studies on cognitive development, but one consistent finding has been that there has been delayed motor development in children who are blind, delayed motor skill development in young children with congenital cataracts, and lower school grades with greater visual impairment in studies done both in Brazil and Spain, as well as lower reading scores and visual motor scores in children with amblyopia. And again, there's a pretty good literature on quality of life, which we'll review in the next session in 2022. But there are a few studies showing lower quality of life, generic quality of life in kids with congenital cataracts, 2 studies that did show that, as well as in hereditary retinal disorders. And in terms of family functioning, there's a measure that's part of the PEDS QL measure that's called the family impact or impact on family module. And using that measure, parents do report significant impacts when their child has hereditary retinal disorders as well as child cataracts. So we do know that these conditions do increase stress for the parents and for the entire family. So the question, I think, for clinical management and pediatric vision loss is, besides doing what you guys do so well, improving visual function through medical and surgical treatments, how can clinicians address young patients' psychosocial issues and help them improve their quality of life? I think that's a key issue for clinical management. And I did want to talk in general then about that, about behavioral health. And behavioral health, of course, refers, it's a pretty broad term that we hear about all the time. And we hear about behavioral health and mental health. Well, behavioral health is the more general term that refers to the connection between behaviors and the health and well-being of the whole person. So it includes, besides mental health type issues, it does include behaviors like eating, physical activity, and sleep, and all the things that impact our physical well-being as well as our mental well-being. Originally, we thought about behavioral health behaviors as behaviors that promote illness and promote health. And so it does encompass mental health, psychological, psychiatric services, counseling, and therapies for all kinds of things, but really looking about the impact of behavior upon health, both physical and mental. And in the pediatric settings, of course, in the primary care setting, well, these are essentially normal kids that do present commonly with behavioral and developmental concerns. And in the subspecialty settings, like you guys work, children with chronic health conditions. This is where, when we think about chronic health conditions, I mean, depending on the study and the definitions, we're talking about, about 30% of children. And if we include overweight and obesity, it's way more. Just think about obesity in children. That's 20% of kids. And kids who are overweight, that's another 15% of kids. So we're more than 1 of 3 kids in the United States is overweight or obese. But excluding that, we're still got 25-30% of the pediatric population with some kind of chronic condition. And these kids cost more money, of course, to care for. But the other thing that's important for today's discussion is really their increased risk for psychosocial adjustment problems. And also their parents have increased risk for their own psychological issues and challenges. The other important point about this is that psychosocial problems are associated with greater medical utilization. These patients are coming more frequently to their doctors, and they're therefore costing more to take care of. Most kids, of course, are healthy, and they have very little of that piece of the pie of health cost. But the kids with more severe chronic problems cost, it's estimated, more than 5 times the cost of healthy kids. And in managed care environments, which we all live in these days, of course, chronically ill kids can be very vulnerable, particularly when psychosocial issues are involved. So these regimens are often complex, they're intrusive, they're chronic. It's assumed they lead to better conditions and health outcomes, but yet we know there's imperfect relationships between what people actually do with regard to the regimen and the outcomes they obtain. So adherence problems across all these conditions are common, and they are almost always related to psychosocial problems. So in the pediatric setting, of course, developmental and behavioral concerns are common. Now we're talking about 25% of the pediatric population, which at any one time is going to present with a significant behavioral concern. And that includes all the kids you guys see. And I don't have to remind you of that, but 1 out of every 4, like normal kids who don't have vision loss, can be expected to exhibit significant developmental and behavioral concerns. So medical practitioners are gatekeepers, actually, for behavioral health services. Serious problems are generally recognized and referred, but referrals we know are usually not successful. Why is that? I want to talk about why that is the case in just a minute. Less serious problems, but still significant issues, may not be recognized, actually. And here we're talking about what we refer to as internalizing problems. That is, kids who are suffering with anxiety or depression, but not outwardly expressing big problems that are easy to see. So there's a lot of barriers for kids receiving behavioral health care. One of the most significant being attitudes and stigma, but there are also our financial barriers, inconvenience, long wait times, not enough practitioners out there, long wait lists, insurance coverage problems. Many states in the United States, mental and behavioral health services are provided by Medicaid HMOs for low-income children with very poor reimbursement. And they effectively exclude licensed psychologists from participating. That is the case in Florida, by the way. I pretty much don't see and can't see kids with Medicaid insurance for that very reason. And then, the bottom line is that most kids who need evidence-based behavioral interventions to improve their health behaviors and health habits, they actually don't get it. So that's, I think, a big problem that we've got, certainly in the US. Behavioral health specialists, though, I think have a lot to offer, certainly. Operating from a biopsychosocial model, which understands that health outcomes are related both to biological factors as well as psychological and social factors. So it makes sense, not only that they are related to all this, but their treatment actually depends upon it, the effective treatment. So one solution to the problem is really the integration of behavioral specialists into healthcare settings. We are achieving that nationwide in many, many institutions, but not yet completely. So interprofessional, interdisciplinary care models for both in primary and subspecialty care, that is state of the art right now. Behavioral health is addressed in team, part of the team treatment approach. But how do we actually achieve that? Well, in some cases, we can have behavioral health specialists close to the clinic for the warm handoff in real time. That's often very difficult logistically to achieve. So what do we do when we back up to the default, which is behavioral health treatment that is referred for another time and another location with another provider? And that's where we have this disintegration of medical care, of comprehensive medical care, because of the barriers that I just mentioned. Well, I just wanted to kind of just put a little bit of discussion about pediatric psychology and what I am, a pediatric psychologist, and what that means, because I think I'm not so much, even medical professionals sometimes don't discriminate between all the different mental health specialists that might be out there. But a pediatric psychologist was defined in 1967 by one of the real, I would say, big figures in the field in its origins in 1967, Logan Wright, who defined the pediatric psychologist as a doctoral psychologist that operates in a non-psychiatric, interdisciplinary healthcare setting. This person would have competencies in child development and as well as child psychopathology. So the emphasis is really on normal development and the utilization of behavior management skills with an applied, economical, clinical utility type of focus. And we operate from a research base, from an evidence base. We can use a lot of screening measures in clinical practice. I mentioned, a little bit earlier, so alluded to some of these. For kids themselves, 12 and older, we can use self-report measures to screen for depression. The PHQ-9 is commonly used. We are using these measures in our clinics in the Department of Pediatrics for kids with diabetes, kids with cystic fibrosis, and other conditions. We can do the same with a measure of self-report measure for anxiety, the GAD-7. And I'll say more about this in just a second. But we can also get parents' report about child problems using a measure called the PSC, Pediatric Symptom Checklist, 17 items. It gives us a score for overall problems as well as subscale scores for internalizing problems, externalizing problems, and attention problems. Here's the GAD-7 screen for anxiety in the last 2 weeks. How often have been bothered by the following problems? And it's scaled 0 to 3. And you can see the items: feeling nervous, anxious, worrying, trouble relaxing, becoming annoyed and irritable, being afraid. So this measure has been around for quite a while. It's freely available. And actually, we have built this into UChart. So you can actually get this in UChart and have your patients complete it. Same thing for the PHQ-9. It's available in UChart. Sorry for you guys that are not at University of Miami, but UChart, I mean our electronic medical record. But because you don't have to pay for this measure, it's freely available and open access. And then these are the 9 items that do screen for depression. And so we have cut points, and we know that if you score a 5 or greater, that you've got at least mild depressive or anxious symptoms. If you score 10 or greater, you've got moderate symptoms. And so these have been validated. And again, these items are right there: feeling tired, and not having energy, and trouble concentrating, and so on. The pediatric symptom checklist has been around for quite a while too, as you can see, first in 1988 and then refined in 99. But it can be used as a good screening measure that parents can complete and get these scores for internalizing, externalizing attention problems, and they do have cut points. So there are measures out there that have good reliability and validity, that have good clinical utility, that can be used to screen when you suspect that there are problems. And then, of course, the quality of life measure. And I've done a lot of research using this measure in kids with diabetes and published papers with Varney, who's the originator of this scale. The general quality of life can be measured with excellent reliability and validity using the PHQ-9. The generic core has got 23 items. It's developmentally appropriate, so there's different versions depending on the age of the child. Parents can provide proxy reports. It's multidimensional, so it maps right onto the WHO kind of definition of quality of life. It's sensitive to clinical change. It's been used in hundreds of studies, literally, and it's available in many languages. This measure, however, is a proprietary measure, so you've got to pay to use it. Although I actually can use it for research purposes without charge because I have a professional relationship with Barney, so that's kind of good. But at any rate, I'll stop there. I know I gave you a kind of a quick overview and delving into this new area for me, in terms of the population, but not new in terms of the issues. The issues are quite similar, actually, in terms of impacts on family, the increased risk for social and psychological difficulties in kids. Well, like other chronic health conditions, there are many challenges, but they, are kind of unique in many ways to the particular patient population with vision loss. So I'll stop here. I want to thank you very much for your attention and open and kind of leave us with where do we go from here in terms of not only our discussion today, but also in terms of future research.
So thank you very much, Dr. Delamater, for that wonderful and really virtuosic presentation on psychosocial development, touching upon quality of life. As a clinician, I come from a family of surgeons, so my father always joked that those who cannot grasp abstract thinking go into surgery. I think that is proven more true than ever hearing your talk. And one thing that you also help us outline is the rich research opportunities that there are in this particular corner. Now, there are lots of questions, and I'm going to try to get through all of them. And they're actually very good because they're the same questions that I had when I was listening to your talk. The first one is actually a very astute comment from Dr. Liz Vanner. I'm just going to say it verbatim. She typed, you mentioned that the study showed no association between, for example, surgical treatment and quality of life. However, it is possible that the children with eyes that were treated surgically had eyes that were less healthy to begin with. So although there were no associations found, this should not be interpreted as indicating that more intensive treatment doesn't improve quality of life. And segue from that comment was actually a question I had hearing the two of the factoids that you mentioned was that primary congenital glaucoma had better quality of life than secondary glaucoma. That leads to kind of a broader thinking that perhaps quality of life is in some ways relative to a person's baseline, whereas psychosocial development, because at least in my very naive and broad stroke grasp of the subject, seems to have more of a defined societal norm, tend to have more of an absolute scale. Would you comment on that? Or am I completely off kilter thinking that that's how things work?
Well, I would not conclude anything really based on one study that might show no relationship between these factors and quality of life. I think, from my review of this literature, I think that there needs to be a lot more done before you can answer questions like that conclusively. I think there's always problems with samples. Are they biased? Well, I think there's some evidence that they could be, and they're not representative of the entire population. So I think that's probably, I think this point really raises the fact that we need more work with larger and diverse samples to really to tease these out. Yeah, so I don't think I think we're not able to conclude much about that question right now.
Okay, that's a very, very fair view. And to jump into a slightly different, combining two questions. One is about resources, and the other one's about screening. Kind of a broad question. One is, you mentioned the three instruments are used to screen for mental health issues, the PHQ, the GAD-7, and PSE-17. Would it be overreaching to apply these screening tools to all children who have a chronic serious ophthalmic diagnosis? And the second part of that question is, let's say we do have a positive screen or we are seriously concerned about mental health issues. Who would you say are the gatekeepers? Would it be to report to the pediatrician and they refer as they see fit? Would they come straight to you, the child psychologist, which would be my preference because I know you take such good care of the patients, or are there some other avenues?
Yeah, I think that's a great question, really. My position is that kids with chronic health conditions, and I'm now talking across the board, not just with pediatric vision problems, should be screened annually for the presence of psychological, social adjustment problems, quality of life issues. That's what we do in the diabetes clinic, for example, at UM. We screen them annually. If they are a positive screen, then we proceed to have more in-depth assessment. So there's a big difference, of course, between screening and evaluation. And a lot of times these are false positives, right? I mean, that's what screening is. Screening will result in false positives. And that's what we want to rule out. We want to identify if this is a true positive, in which case we do a more comprehensive evaluation. I certainly think primary care doctors, should be informed and involved, and they need to be aware of what's going on with the kids they care for. But as subspecialists, you guys, I think, are ideally suited because you're probably seeing them more frequently than the primary care doctor is anyway, unless they have get a bad cold or tummy aches that they got to go see the doctor. They're going to see you on a pretty regular. You're going to know them chronically, right, over time. So they got a really important relationship with you, I think, and you can refer them directly, certainly. So to determine whether or not these are significant issues that can be addressed and should be addressed. What we do in the diabetes clinic, for example, is if a kid does screen positive, we do an evaluation. We either provide that intervention if we can in-house or refer them elsewhere. But then the next time they come back to clinic, we're going to also screen them again as a follow-up. So once you achieve that threshold, we want to reassess, rescreen. Now, again, screening measures can be done at low cost and with little time and effort. Some of these self-report measures. You can actually use self-report with some kids younger than 12. I mean, kids as young as 8 and 9 can also report reliably about their own functioning. Sometimes some kids, but we can certainly use parent reports. So I think I wouldn't just send them back to the primary care doctor because then you've lost your opportunity. It's going to take time to see them, and then that doctor is going to be in the same position as you. Well, what do I do now? So may as well just. So that's why I would encourage you as pediatric ophthalmologists to use these measures in practice. So yeah, I'm an advocate of at least annual screening.
That's actually very wonderful guidance. And now that you mentioned, you do have smart phrases built into the electronic health records. I think all of us here at Bascom would absolutely love to see them. And in a way, help is one click away. So that's great. To kind of expand a little bit more and maybe a little bit more complexity, I think all of us who have taken care of children since their birth have witnessed on many occasions where, loving, distraught young parents that will come in with their baby boy, baby girl. And then over time, you see the relationship start to fall apart. You see the stress signs, etc. And the question that I have and was touched upon in one of the audience question was when do we at least suggest that the parents find help? I don't even know if they realize that there is a solvable problem. And I think it's a little bit more complex because these are the caretaker. They are not directly our patients, although their mental health well-being directly impact our patients' well-being. What would be your suggestion?
Well, I mean, that's another great question. And I'm so glad you brought it up, actually, because, it's not that easy to make a really effective referral for mental health treatment. It's not, right? You can see it happening in the exam room. You can see the parents' stress. You can see they're falling apart, or you can see the relationship between the kid and the parent is not good. And So how you can get them to actually follow through on the referral is really a matter, I think, of the clinician's skill themselves in doing that. Now, if you say, wow, I want to send you to see a psychologist or psychiatrist, I think you really got some important issues here you should be working on. How are most people going to respond to that? Probably very defensively. What are you talking about? You think I'm crazy? So I think it's, but really taking the time, I think, to listen to what is going on and how they're feeling. And so asking a few questions about how they're viewing this situation, an open-ended question. Gee, it's, a reflection and an observation, a reflection, an open-ended question. Gee, it seems like you guys are feeling a lot of stress right now. I wonder, can you tell me more about it? Now they're going to tell you something. And then you could say, wow, that sounds like it's really difficult. And so you give an empathic response back. I wonder if you would be open to talking with someone that can help you address these issues and try to improve the situation at home. And, once you go that route, they may be more likely to be receptive to actually following through on a recommendation, particularly if you know someone you can refer to. That always helps. Well, I know Dr. So-and-so that's over here at the medical center has seen many of our patients and really has seemed to help. Would it be okay if I, give you that information and you could go, or I can contact them myself. So now you're asking permission and you're getting them involved in making them feel like they've been heard, that you understand them, and that you are empowering them to go ahead and take the next step. So it's not a matter of a prescription. Okay, I'm going to send you to see Dr. So-and-so now. And that's a little bit different. That's more the biopsychosocial model than it is the sort of the straightforward medical model where you say, okay, you got this problem. I'm going to refer you to Dr. So-and-so for another consult. And that is accepted by many people, but not easily for mental health treatment. And that's the catch, I think.
That's, I think you touched upon something very important also. And this is an idea that Dr. Grajewski and I have been kind of playing with in our minds, which is to really normalize mental health assessment and intervention as part of pediatric glaucoma and pediatric anterior segment care. Now, this is kind of a out of space kind of question. If there were, if the standard practice were to be every child who were diagnosed automatically gets a referral, and we tell the parents, if you don't have any problem, that should be a very short visit and a very pleasant one, that shouldn't take you much time, just to normalize the involvement of mental health professionals as well. How do you think that will be received, and has that been done already in other subspecialties?
Well, I mean, again, you're right on spot with that because, integrated behavioral healthcare does normalize that, because it's not as if you need to have a big mental health problem to see the psychologist, the psychiatrist, the social worker, whoever it might be, that's part of it. If you're part of a team, then it is normalized because that person is seeing every patient, and understanding that, behavior management of chronic illness is really about learning. It's really about learning how to manage a regimen. We're learning how to, incorporate everything that this disease, all the challenges that are imposed upon the child and the family, managing that into their normal life so that it's all learned behavior. And that's where I think that the pediatric psychologist really helps out here. It does recognize the important disruptive roles of significant mental health issues, but it also helps to normalize and facilitate good management, good adherence, and good adaptation generally. So I think when that is seen by the patient as part of normal treatment and part of the team approach, I think that there's a lot less barriers to actually going ahead with that. So yeah, I think that's exactly what's needed.
And to kind of segue on yet another very important avenue that you brought up, both in the comment you just made and in the slides that you have presented, it seems that a large part of kind of life outcome ties onto the patient and the parents' health literacy. And so I'm curious, as far as my own clinical practice goes, whatever time I have left over in my 15, 20-minute slot after doing everything I need to do for the patient's eye, I try to answer their questions and try to whip out the eye model and try to squeeze in a little bit of education. Do you think perhaps there should be more of a organized, multidisciplinary effort to educate these parents in term both in the disease, in terms of the mental health aspect, in terms of kind of social and life planning aspect? And again, is that already being done? I can imagine this will take a lot of effort, Dr. Grajewski, to come up with almost a subscription, monthly or bi-monthly webinar from different area geared just for the parents and the patients so that we can keep that level of health literacy up. And just by doing that, we can perhaps improve both the psychosocial development and quality of life. Your thoughts?
Well, I mean, again, Peter, you're right on target. I mean, as you were saying that, well, there's 2 points I want to make. One is that we have one study on health literacy in pediatric glaucoma. That's it. It's a small study. It's correlational. It had like 47 patients, I think. So clearly we need more in that. But there's a big literature on parental health literacy in other chronic conditions. So my colleagues and I published a paper a few years ago looking at the parent health literacy in relation to diabetes management in young kids with type 1 diabetes. And sure enough, it came out exactly the same. Parents of low literacy didn't understand as much, they didn't, and their kids didn't do as well. So yeah, it's a very important family level variable. The other point I wanted to make, though, that you just reminded me of a study that was done in at Joslin Diabetes Clinic in Boston, in which they had a curriculum that was like 10, 15 minutes at every clinic visit. Besides seeing the endocrinologist, the patient met with, it was a bachelor's level, research assistant in the study, but this was an RCT. So it was a controlled clinical trial, basically. But these kids and the parents received psychoeducational materials about diabetes and its treatment at each of like 4 to, I think it was 6 sessions over like, a year and a half. And then they were followed for another year. And the results showed that the families that received this, they didn't have problems to begin with. They weren't identified. They were normal kids in the diabetes clinic. Families that received this have kids who manage diabetes better, not just their regimen adherence. Their glycemic control was improved as a result of, in the RCT, receiving psychoeducation as part of normal clinic visits. So that's a model of integrated behavioral health care that was shown to improve health outcomes and health behaviors as well, which presumably are the mediator, right? They're improved behaviors, they're getting improved outcomes. So yeah, I mean, I think that would be a very exciting thing for you guys to do in the treatment of childhood glaucoma, is develop that type of preventive psychoeducational healthy family adaptation approach.
That's wonderful, wonderful ideas for large collaborative project, and that's really suited for really all the members that are participating here from the Childhood Glaucoma Research Network. Now that we're reaching close to the top of the hour, I'm going to hand the virtual microphone back to Dr. Grajewski for her final thoughts and final comments.
Thank you. And Alan, that was incredible, just incredible. And I feel like we have a lot of work to do. But I do think CGRN, our network, if we collaborate together, we could probably really change this aspect of our care for these kids and their families. I mean, it's doable, absolutely doable. And maybe at our next meeting, we'll be able to, when we meet with CGRN again, which which brings up what is next for CGRN as well. I just want to mention we have a couple of opportunities coming up where our CGRN members have events planned, and our next one will be actually in New Orleans at Academy. And I see Elena on the call as well. Elena, this is something we need to put on our agenda for that, I think, don't you? And we'll do that. There's a large meeting, and Peter, I think you've been working with Shamita on the Indian Pediatric Glaucoma Society meeting. That's going to be in December, so we could maybe have some follow-up at that time if we move towards something collaborative with respect to this project. And then finally, there's UKPGS, which of course most of the people on this this meeting today attend as well. So I just wanted to remind everybody about that. But it is an opportunity for us to collaborate on these. Just another little mention for Academy for those. Who knows if it's going to be virtual or not. Let's plan on it not being virtual, and we'll all be there face to face, which would be lovely. Let's see you at our CGRN meeting. And if Alan, if there's a lot of interest in this, I'd like to invite you to join us. And let's, to the meeting and help us think of how can we harness the energy of our international organization. There's a lot of countries on here even today that we can get something together to move forward on this. There's also our surgery course, and I want to thank everybody in CGRN who we have so many people helping. And this year we have a wet lab, which is really cool. We'll see how that goes if we do it in person. And we're coming up to the end here. I just want to thank everybody. And Alan, I want to thank you very much. Dr. Rahi, I want to thank her as well. She's wise already because she saw that this would take an hour, and she was right. Although she didn't choose this path, this was unforeseen. As she mentioned, this was an opportunity. And we will focus on, first of all, a call to arms for us to collaborate and start working on this in between. And then by January, when we have part 2 of this Kolokotrones lecture on patients, parents, and providers, we may have a plan laid out. Don't you think, Peter? Maybe so. And
yeah. These and I have to say, all of our collaborative project all came from inspiring talks like the one that Alan just gave, and also from Dr. Wiggs and Dr. Young the previous time. So yeah, that's a lot of work ahead.
Yeah, but these inspiring talks are terrific. Alan, again, thank you so much for
being the talks have got to be followed by some action plan, though, and that's what I hear you say with your call to arms. And I just want to thank you again. It was really a pleasure to kind of delve into this. Again, it's a new area for me, but it's a familiar territory, actually, in terms of the issues faced by kids and their families. And I just saw in the chat greetings from Mainz, Germany, and reminds me what virtual. How close we are virtually. I was in Mainz, Germany years ago for an international conference, and it's a beautiful little city. I loved it. I loved walking the streets there. So thanks again. I appreciate it.
Thank you. And I hope to see everyone in New Orleans. And any other questions, just reach us. If you're not a member of CGRN, please contact us here at Bascom Palmer at the Balkan Center. And here's signing out. Thank you all very much. Bye-bye.